Hello class, my name is Cassandra Samuel and my research was done on is oral contraception use a risk factor for breast cancer. A little bit of the rationale behind my study. The leading cause of cancer deaths among women is as a result of breast cancer. Every year, 521,000 women die as a result of breast cancer. We know that oral contraception is used by women to plan the size and growth of their family. Studies have, however, shown that there is an association between OC use and breast cancer. Some key definitions. Breast cancer occurs when breast tissue begins to grow out of control. It's classified on molecular subtypes, and the subtypes that we'll be looking at are ER positive, ER negative, triple negative, luminal A, and HER2 positive. Oral contraceptive is often referred to as birth control pill. This medication primarily contains hormones of estrogen and progesterone in different levels. The medication is used normally to prevent pregnancy, but is sometimes used as a hormone replacement therapy, to treat the effects of menopause. The three articles that I look at. Article 1 by Berber et al. Is oral contraceptions and breast cancer risk overall and by molecular subtypes among young women. Article 2 by Bertha et al. Is a case control analysis of oral contraceptive use and breast cancer subtypes in the African American Breast Cancer Epidemiology and Risk Consortium. And Article 3 by Ellen Joy Dale et al. Is priority, hormones, and breast cancer subtypes results from a large nested case control study in a national screening program. A little overview of each of the three articles. Article 1 is a case control study. It's among women with cancer ages 20 to 44. The data is collected primarily in the Seattle area from 2004 to 2010, and the data on the contraceptive use was collected via in-person interviews. There were 985 cases and 882 controls. Article 2, Bertha et al., is also a case control study. It, however, was conducted on women ages 20 to 74 who are primarily of African American descent. The study collected the data in North Carolina, and later they collected some of the data in New York and later New Jersey. The data was collected again from the African American Breast Consortium, and there were 2,891 cases and over 100,000 controls. Article 3 was the largest of all three articles. It's a nested case control study. It was data was collected from the Norwegian Breast Cancer Screening Program in 2006 to 2014, and women were ages 50 to 64. And the difference between this one and the others is that the data was the hormones or the oral contraceptive use was primarily to alleviate symptoms of menopause. This was the largest of all three studies, and over 340,000 women were involved in that study. A little bit about the article summation. We'll start looking at the exposure. In terms of exposure, for Article 1, we looked at the duration of the exposure and the percentage of estrogen-progesterone combination. It was kind of hard in that article to actually collect data in terms of progesterone concentration, since progesterone is normally administered at a very low dosage. So they differentiate between low dosage of estrogen and high dosage of estrogen. The data again was collected via personal interview. In terms of Article 2, again, they look at duration, and the data was collected via telephone. And Article 3, it was primarily the use of the hormone as it relates to hormone replacement therapy, and that was conducted via questionnaire. In terms of outcome, it was breast cancer for all three, but as it breaks down by categories. As the results, odds ratio results. In Article 1, it was found that there was not a significant difference in the odds ratio for current users. Notice that the confidence interval includes 1. However, for 5-year duration, the odds ratio for users was 1.6, and the confidence interval was 1.1 to 2.5, which is above 1. That is significant. In Article 2, the odds ratio was greater than 1 for all 3 of the cancer types, and for triple negative, the odds ratio was 1.78. It was the highest of all 3. The confidence interval was between 1.25 and 2.53. For Article 3, the odds ratio was primarily high for the luminal A breast cancer type. The odds ratio was 2.92 with a confidence interval of 2.36 to 3.62. That's almost 3 times the normal risk. The Henneken's criteria. In terms of chance, for Article 1, as I said earlier, the current users, there wasn't any significance in the odds ratio, but you'll notice for the 5-year users, the p-value was actually less than 0.05, so there was a significance in the odds ratio. For Article 2, the odds ratio within 5 years was 1.46 with the confidence interval above 1. And for ER negative, the odds ratio was 1.57 with the confidence interval again above 1. And for triple negative, the odds ratio was 1.78 with the confidence interval again above 1. For Article 3, the odds ratio, you would find that, as I said earlier, for the luminal A cancer block type, the odds ratio was actually 3 times what the regular ratio was for women who did not use the hormone replacement drug. In terms of bias, for Article 1, we're looking at miscalculation and recall bias. Again, for Article 2, there was recall bias, and in Article 2, there was some bit of selection bias in the sense that you had women of African American descent, and no classification was made for household income or wealth status. In Article 3, selection bias and misclassification bias. In terms of confounding, for Article 1, age, race, education, household income, and length of OCUs were all controlled. In Article 2, age, body mass, and length of OC was controlled. However, race and ethnicity was not controlled for neither household income. In Article 3, age, race, education, body mass, and the number of births, of live births, were all controlled. In terms of strength of association, in terms of Article 1, for women who had use of greater than 15 years, the OC was weak, there was a weak association. In terms of Article 2, all 3 were greater than 1, but they were all 3. They were all weak. And in terms of Article 3, there was a 3-fold increase for the luminal 3 hormone replacement therapy. So it was a very strong association. In terms of biological plausibility, they were all yes, and consistency, yes. In terms of temporality, it was noted that for longer use in Article 1, the odds ratio was higher. The same was also true for Article 2, and in Article 3, there was actually a 10% increase in breast cancer as a result of duration of OC use. Strengths and weaknesses of the articles. Article 1, or Research 1, risk was broken down in terms of strengths. Risks were broken down by length of use. There was control between control and exposure groups. They were comparable, so that was good. In terms of Article 2, there were very large sample sizes used. The cases were broken down over 5-year intervals, so that was very good. And in terms of Article 3, that was the largest size that we dealt with. Case and control groups were comparable. In terms of weakness, Article 1, the nature of the way the data was collected just by personal interviews, telephone interviews, errors can occur that way. In Article 2, definitely race was not confounded for, and income was not confounded for, and also we also have to indicate that the case to control, the control group was way larger than the case group. In terms of Article 3, some of the weaknesses, we should know that there's a rare some of the breast subtypes that are used are very rare, and the study was very large, which was a good thing, but also was a bad thing in that it could pick up unnecessary noise. Some conclusions. There's a higher prevalence of breast cancer among women who have used oral contraceptive. Long-term use of oral contraceptive tends to increase the risk of breast cancer in women, but definitely further studies should look into more classifications as well as the different subtypes and the different molecular data. One of the areas where the data was short in this aspect was that the size of the breast cancer was not analyzed, so we need to do some more study on that. Here are my sources cited. Thank you.